Dr. Vasan, I just wanted to let you know that there are people in-house physically here, and then a lot are virtual, in clinics across the city. But thanks, everyone. We are thrilled to have Dr. Aditi Vasan with us today. Dr. Vasan is a pediatric hospitalist and health services researcher at Children's Hospital of Philadelphia and an assistant professor of pediatrics at the University of Pennsylvania Perelman School of Medicine. She works closely with the Penn Center for Community Health Workers, a center that leads implementation and evaluation of community health worker programs across the University of Pennsylvania health system. Dr. Vasan's research aims to promote health equity by improving health and social service systems serving children and adults living in poverty. Her current work is focused on implementing social needs, screening and support programs, increasing access to government benefits, and developing strategies for addressing social needs among medically complex children. Please join me in welcoming Dr. Aditi Vasan to the Tilman J. Fertitta Family College of Medicine Grand Rounds.
Thank you so much, Dr. Buck and Wendy, and thank you so much for having me. It's such an honor to be here and to present to this audience. I'm really looking forward to what I hope will be an interactive discussion today. So please feel free to interrupt with questions or put questions in the chat for those of you joining virtually, and I hope to leave plenty of time for discussion. I'm really excited to be here to talk about community health workers really as a workforce and the use of community health worker programs to promote health equity in the US. I have no conflicts of interest to disclose. So as an overview of today's talk, I'm going to start by discussing population level social determinants of health and individual level social needs, how those compare, and how both of these factors combine to drive disparities. I'm then going to talk about community health workers and specifically their role in promoting health equity in the United States. I'll synthesize some of the evidence supporting the impact of CHW programs on population health, patients' experience of care, healthcare costs, and health equity. And lastly, I hope to identify some areas for future research and policy to support CHW integration and effectiveness in healthcare and public health. In short, I hope that this talk gets you guys excited about community health workers and the incredible work they can do to help support our patients and their families. So I want to ground us in a discussion of health equity, inequity, and systems change. When we think about health equity and healthcare equity, I think it's important to remember that these are slightly distinct concepts. There's a lot of definitions thrown out for health equity. One that I like is from the Center for Medicare and Medicaid Services, and they say that health equity really is attainment of the highest level of health for all people, where everyone has a fair and just opportunity to attain their optimal level of health, regardless of their race, ethnicity, disability, sexual orientation, gender identity, socioeconomic status, geography, preferred language, or any other factors that might affect access to care and health outcomes. And then healthcare equity, I would say, is the idea that everyone should have a fair and just opportunity to access and receive high quality patient and family centered healthcare as needed, again, to get to their optimal level of health. So does equal care result in healthcare equity? That is, if you give everyone the same healthcare, does that mean care is equitable? And the answer, I think, is not necessarily. So in this graphic from the Robert Wood Johnson Foundation, they contrast the idea of equality, meaning everyone gets the same set of resources regardless of what they need and if it's right for them. Here you can see a crossing with a sign set up, but there's a steep curb that might not be right to accommodate everyone who's crossing. Versus equity, where everyone gets exactly what they need, understanding that people have unique barriers, circumstances, and conditions. And we'll talk more about why community health workers are particularly skilled in promoting equity. But this graphic shows you not everyone is getting the same support, but everyone is getting the type of support that they need given their unique barriers and conditions. And then does healthcare equity result in health equity? So assuming that everyone is getting equitable care, the type of healthcare that they need, is that going to lead us to equitable health outcomes? Again, I would say the answer here is not necessarily. So when we think about the scope of factors that affect a patient's health and well-being, I think it's humbling, especially for me as a clinician, to recognize that biomedical factors, the things that we're typically addressing within the hospital or clinic walls, are really just the tip of the iceberg. We know that these factors drive about 20% of health outcomes, but the remaining 80% is really driven by these social determinants of health under the surface. Things like socioeconomic status, income security, food insecurity, and housing conditions play a much bigger role in determining health outcomes than the things that we often are directly addressing in the context of clinical care. And so when we talk about social determinants of health, I think sometimes people use the terms social determinants of health, social risk factors, and social needs interchangeably. And I just want to draw a few distinctions. When we think about social determinants of health, I really think about that at the population level. So the conditions in which people are born, grow, live, work, and age. Some examples include economic stability, education access and quality, healthcare access and quality. And the social determinants of health or social drivers of health impact everyone and aren't inherently negative. And importantly, these typically affect populations, so not individuals, but whole groups. And then social risk factors are social determinants that might be associated with negative health outcomes and that usually are measured on the individual level, something like food insecurity or housing instability. So when we talk about social determinants of health screening, what you're typically screening folks for is social risk factors, right? You're not necessarily asking about their social and community context, their neighborhood and built environment. You're really asking at the individual or at the household level what their needs are. And then social needs, moving from risk to need, is a person-centered concept that really incorporates an individual's perception of their needs. So you might screen positive for food insecurity risk, but you might say, what I really need to help me right now isn't more resources for food, it's actually resources for housing or for transportation or it's social support. So the idea of social needs is that we should really be thinking about centering the individual who we're supporting and what they feel like is most pressing to intervene on. And then as we consider social determinants and social needs, I really like this graphic that shows potential upstream, midstream, and downstream levels of impact. Clinical care, so a lot of what we focus on in clinical settings is really a downstream intervention, right? When we put into place medical interventions, we're often intervening on the effects of social needs long after they occur. For example, when I treat my patients for type 2 diabetes, I'm intervening on the effects of inadequate access to nutritious food over often a long time period before I see them. A lot of what we focus on are these midstream interventions. It's been great that there's been more excitement and enthusiasm around including patient screening questions about social factors like housing and food access, and then using people like social workers, community health workers, or community-based organizations as an important bridge to help support individual social needs. But I'll argue, and I'll get back to this at the end of my talk, that it's also important that we think even further upstream, right? And think about the laws, policies, and regulations that create community conditions supporting health. And I believe that community health workers can have an impact not just at the midstream level, but also at the upstream level in informing and improving community conditions. And I want to ground our discussion today in the idea that fundamentally, health inequity is not a problem of inferior biology or of poor individual behavior, but really of how our institutions, specifically our healthcare institutions, but also our educational institutions, our justice system, our political institutions, do not treat everyone equally. And so rather than intervening on individuals, I like to think about my work as work that intervenes on systems and really tries to make them more just. And I would argue that health equity really requires building equitable systems. So using the skills of empathy and understanding the challenges that our families face in trying to achieve and maintain health, and systems thinking. So considering how these challenges might have been created and perpetuated by existing systems and how we can intervene to address them. So I'll use that to transition to talking a little bit about community health workers, who they are, and what their history has been in the United States. So a community health worker is a frontline public health worker who is a trusted member of and has a close understanding of the community that they serve. This trusting relationship really enables community health workers to serve as a liaison between health and social services and the community to facilitate access to services and improve the quality and really cultural and structural competence of service delivery. Community health workers can also build individual and community capacity, so they can increase individuals' health knowledge and self-advocacy. They can provide community education, social support, and advocacy. And there's a lot of definitions of what community health workers can do. I like this set of core competencies because it was really something that came out of the Community Health Worker Core Consensus Project, a project in which CHWs themselves were asked to define their role and talk about the services that they feel they provide. I think a lot of people focus on number 2 and 3 on this list when they think about who community health workers are and what they do. And certainly they can provide culturally appropriate health education and information, and a lot of their work is providing care coordination, case management, and systems navigation support. So making our really complex health and social service systems easier to understand and navigate. But I would argue that a lot of the really important things they do fall outside of these 2 categories. So they can provide individuals with coaching and social support. And when we talk to our community health workers, I think they'll tell you that a lot of the most meaningful work they do is in that area of social and emotional support for people who haven't previously felt trust and support from the healthcare system. They can advocate for individuals and for communities. So individual level advocacy might look like referring someone to a particular resource, but community health workers can also use their understanding of individual level social needs to then advocate on the community level and say, hey, these are the changes we need to make to better support the patients I serve and individuals like them living in the community. They can provide direct service and provide direct care. And really the root of community health workers is in global health, where they primarily function in this direct service role. They can help to implement individual and community assessments. So at CHOP, being a nonprofit hospital, we complete a community health needs assessment every couple of years, and community health workers, both at CHOP and Penn, play a role in understanding community. I think serve a really important function in making community members comfortable disclosing the needs that are most important and relevant to them. And then community health workers can also really participate in evaluation and research. And this is something that we've tried to do with our own programs, is not just design an evaluation that's going to look at the outcomes that are meaningful to our health system, but also really ask community health workers and patients and families themselves, what do you think are the most important outcomes to look at, and how should we assess them to look at whether and how this intervention is working and how we can make it better. And then what skills do community health workers need? Again, this came from community health workers themselves. And often we think about first communication, interpersonal and relationship building skills, and service coordination and navigation skills. So these individuals have to be empathetic, they have to be effective communicators, and they have to understand the complicated health and social service systems that they're navigating. But more than that, there's a whole host of other skills that I think are beneficial, things like capacity building, advocacy, education and facilitation, community assessment, as we talked about with community health needs assessments, outreach, evaluation and research skills, and then knowledge base. Many of these are skills that can be developed and nurtured with standardized training. I would say the most important quality for community health workers to have is empathy and a genuine interest in helping patients and families. And that's often something that can't be taught. So in our own CHW programs, I think we really focus on hiring people for personality characteristics like empathy, effective communication, and really a genuine passion for connecting with people who are facing challenging circumstances. And then we focus on developing standardized training that will help them build a lot of these concrete skills. And then the C3 project also asked community health workers, who are community health workers, right? What are their core qualities? What's most important? And this is a word cloud that they made based on the responses. Some of the things that jumped out to me include being compassionate, self-directed, open-minded, motivated, and persistent. I think persistence is key, and any of our community health workers would tell you that when you're working with families who are often facing a lot of challenges and competing priorities, and you're helping them navigate a lot of complicated systems. So I could tell you all about community health workers and what they do, but I would love for you to hear from a couple of community health workers in their own words. So I'll play a couple of videos now. The first is from Cheryl, one of our community health workers here at Penn.
I called a patient recently who needed assistance with food. only to learn a lot about her. She was depressed because her mother passed away, her best friend passed away, and then her significant other passed away. So she'd been grieving, but haven't been really talking to anyone. So we talked about her need for food, and getting her yard trimmed because she's an older lady. So I was able to connect her with food resources. She was able to pick up food, and people were able to deliver food to her home. But the most important thing about that conversation was the fact that she just didn't have nobody to talk to. We talked for like 2 hours, just me getting to know her, about her family, everything she had been through in life. Then we found out that we both graduated from John Bartram High School, even though it's like 30 years difference. But she felt good being able to talk. And she was saying that this is the first time she had actually ever spoke to anyone about what she was going through. And she was just so happy that I took the time out to just call and just talk to her.
And then I have one more video from a community health worker at one of our partner health systems in Tennessee.
I personally became a community health worker because it's something that really is a dream job for me. Community outreach and being part of the community and doing things to help the community is what I've always been about. The community health worker program is designed for patients who come into the emergency room instead of use their primary care physicians. They're coming to the emergency room to be treated for simple things instead of actual emergencies, as well as people that live just in the generalized Bristol area and people that also are just needing extra support and maybe help with social needs that have never been addressed with them before. Taking community health workers and putting them in the communities to work with them one-on-one and learn what's important to them. We're taking a personal interest in their lives. So we're connecting the healthcare system to their actual personal lives and making them overall more comfortable with the way that our health system works. But one of our success stories is actually about a young lady that's in her late 30s. I met her in October of 2020. I actually met her on the street. We were volunteering for with a church group handing out food for the homeless. And we stopped to talk to her. She was so excited to let us know that she had just had a really good interview and she felt like she was going to get a job. I just felt really connected to her for some reason. So I gave her my card and just told her, you know, if you ever need anything, call me and I will do everything I can to help you. About a month passed and she called me and she let me know that she did get the job. She was still homeless, but she was riding the bus every day. But she did have some things that she thought that I could help her with. I did our meet the patient interview with her and very quickly realized that her needs were a lot different than a lot of people's. She wasn't really concerned about her health right now. She wasn't really concerned about anything other than the fact that she had some kids that were in foster care that she was desperately wanting to get back, that she had been addicted to drugs at one point. I was able to start contacting the Department of Social Services for her. We went apartment searching. She found one on her own. I had been helping her and giving her some resources, but she ended up finding her apartment by herself. And she said, well, I just got an air mattress, but it's a warm place to stay. So myself and the community health worker team was able to reach out to a ladies group in our area, and they have completely furnished her apartment. Everything that she needs is completely there, that was provided by our community. And they just completely surrounded her with all of this wonderful things and all the love that they could give. We were able to reach the Department of Social Services, and she has connected with her children again. She is seeing them on a weekly basis. She just needed the extra encouragement and somebody there to believe in her. The community health worker program is one of the best things that I think that Valid Health has done to help our community. Bristol Regional's pilot program took off and was doing great things. So we've actually been successful in expanding. So we're going to be able to reach so many more people in our local communities and help them be healthier.
So, I could watch these videos all day. I think it's really special to hear from our CHWs in their own voice about the work that they do. And I hope that hearing from Cheryl and hearing from Brianna, you recognize that some of the things that make community health workers special are really their trustworthiness and ability to build bridges between health systems and the communities they serve, their ability to provide patient-centered support. So I hope that a common thread that you heard in both of our CHWs descriptions were that they were not just providing patients about resources tailored to a need identified on a screener, but really meeting patients where they were, right? Understanding their needs, what was most important to them, and then figuring out how to get them connected with the right resources and support. And then really community health workers can also build community capacity through outreach, community education, social support, and advocacy that informs program and policy changes. They can be a bridge sometimes between existing resources that exist in the community, like the women's group that you just heard about, and individuals who are in need, and can really help make those connections that might be much harder for an individual who is struggling with these needs to figure out on their own. And I think that community health workers are really an important part of the social needs screening and support system because they can help families in a variety of different ways. So the Social Interventions Research and Evaluation Network, which is a research network run out of UCSF, has put together what they call a logic model for social needs screening and intervention, or social care. And what they describe is a bunch of different pathways by which identifying social risks can lead to improved health outcomes. The simplest pathway, and the one that we think about, right, is we identify a social risk like food insecurity. We connect someone with social services. I give you information about a food bank. You decrease your social risk, so you get that food, and then that improves your health. But I think what Siren highlights is that there's also other ways in which these interventions might work. Really importantly, connecting someone with a social services navigator, like a community health worker, can improve emotional support, which can directly lead to better health outcomes. As you heard from Cheryl, the woman who she talked to and worked with hadn't really had anyone there for her in all of the grief and challenges that she was facing. And just by being there on the phone with her for 2 hours, I would argue Cheryl really supported her health in ways that might be more difficult to measure, but are no less important. There's the healthcare connections pathway. So in addition to connecting people to community-based resources, community health workers can help connect people with outpatient healthcare, both by giving them concrete resources. Here's transportation to your next appointment, by helping them navigate administrative tasks. Here's who to call to make this appointment. Here's who to call again if you don't get through the first time. Here's how to navigate the phone line, especially if you're someone for whom English isn't your primary language. And they can help build trust in healthcare, right? You can imagine that someone who's had a relationship with someone like Cheryl or Brianna, who's a community health worker based in a health system, might then be more likely to seek care from that health system, recognizing that the health system employs people who are like them, who care about them, who want to understand them. And then there's also a tailored clinical care pathway that I think is really important. So in light of understanding someone's social needs, there are ways in which you can modify their clinical care to better meet those needs. For example, if I learn that a patient I'm seeing inpatient has difficulty with transportation, I might work upfront to schedule their follow-up appointments all on the same day so that they're not making multiple trips back and forth to the hospital. That's a small change, but it's one that could make a big difference in their ability to adhere to care. And I present this logic model here because I think that community health workers are often really able to capitalize on all 4 of these pathways in a way that healthcare providers can't always in the time-limited context of a 15-minute visit or even a 3 or 4 day inpatient stay when there's a lot of competing priorities. CHWs really intuitively understand not just how to connect people with social services, but also how to provide emotional support, build trust in the healthcare system, and because they understand both healthcare and community systems, how to coach the team in tailoring and changing their care plan to families' unique needs. I'll talk just a little bit about the history of community health worker integration in the US, mostly to say that this workforce has been under-recognized and under-supported for a long time. CHWs really started their work in global health, where often there are people providing direct care in a lot of communities that don't have access to other healthcare. In the US, though, they were included in really a few federal anti-poverty programs and public health department collaborations as early as the 1960s, but there wasn't a standardized national system to support CHWs or financing for CHW services. The Indian Health Service was one of the first groups to really embrace the community health worker model to support Native American and Alaska Native tribal members. But really through the 1970s and 80s, and even into the 1990s and 2000s, most community health worker programs operated through disease-specific, short-term public or foundation or private grants. And several bills that were proposed to increase federal and state funding for community health workers were actually proposed in the 1990s and 2000s, but none of them was approved. I think, fortunately, we've really seen that change over the past 2 decades. And a lot of that came out of the Affordable Care Act in 2010, which really catalyzed a shift towards value-based care. So care that's based on not the number of procedures you perform, but really the health outcomes for your population. And that helped build the basis for expansion of community health worker programs in healthcare. In 2014, CMS, the Center for Medicare and Medicaid, approved pathways for financing community health worker programs through state Medicaid agencies. And really just in the last 4 years since the COVID-19 pandemic, we've seen renewed attention to the role of community health workers in addressing health inequities. The CARES Act passed during the pandemic included funds to expand CHW capacity. And since 2020, there's been new federal legislation that supports Medicare reimbursement of CHW services, and several states are now funding community health worker services for some Medicaid beneficiaries through state plan amendments. So there's been a lot of interest in supporting this really essential public health workforce and in supporting them in a way that's more sustainable than a one-off grant. There's a few different models by which community health workers can be integrated into public health and healthcare, and I'll just illustrate what they are. You can have community clinical linkages where community health workers are directly employed by CBOs. That's often really great for having community health workers who are embedded in communities and who have a great understanding of community-based resources. But sometimes it can be trickier for these folks to access things like health records and healthcare systems because they don't exist within a health system. You can have CHWs who are employed within healthcare systems. So this is our model here at Penn, where we have a workforce of CHWs primarily serving patients in our surrounding area in West and Northwest Philadelphia, but who can also serve patients in a broader catchment area and who our health system invests in, recognizing that we see a return on investment in terms of improved population health. There's also payer integration. So as Medicaid payers in particular move towards addressing health-related social needs, some of them have employed people like community health workers or care navigators to help address needs for their beneficiaries, again, recognizing the important role this workforce can play in addressing people's needs. And then there's also community health workers at public health departments. I think this is a really common model during the COVID-19 pandemic when a lot of CHWs helped with contact tracing and connecting folks to vaccines, connecting folks to medications. I think this can be a really important model for CHWs, especially in the context of cities like Philadelphia with a high level of social need at the population level, and sometimes with multiple health systems. I think one benefit of both the payer-based and the public health-based model is that patients don't always seek care in just a single health system, and it can be tricky for health system employed CHWs to help them navigate across multiple systems. Whereas if you're employed by a public health department or by a payer, it can be easier for you to sort of seamlessly navigate those different contexts. And so what's the evidence that supports these programs? I've told you how wonderful CHWs are. You've heard that from the CHWs themselves, but what do we know about these programs and how they work? So I'll start by really framing the ways in which community health workers can support 4 of the 5 components of the quintuple aim. Some of you might have heard of the triple aim, which is something released by the Institute for Healthcare Improvement back in 2007 that really gave healthcare the goal of achieving these 3 aims simultaneously. So improving patient experience, improving health outcomes, and lowering healthcare costs. Since then, there's been the addition of a quadruple aim, 4, which is clinician well-being, and a quintuple aim, which is health equity. And while I'll focus on 1, 2, 3, and 5 here, I don't want to understate the impact that community health workers can have on clinician well-being. I think one of the things that really contributes to burnout for clinicians often is this sense of moral injury or insufficiency when we encounter social needs that are impacting our patients but feel powerless to intervene on them. And so I think community health workers, by supporting our patients, are also supporting us as healthcare workers in making it easier for us to do our job, knowing that our patients are being supported and that our health systems and social service systems are investing in supporting their health in other ways. We know about, in terms of patient experience, that community health workers can increase rates of cancer screening across several systematic reviews looking at breast cancer, cervical cancer, and colorectal cancer. We also know that working with a community health worker can increase patients' access to primary care, including post-hospital follow-up, asthma care, and adult hypertension care. In several studies, we've seen improved patient-reported quality of communication, for example, hospital discharge communication, and quality of primary care in some studies, although others have mixed evidence on satisfaction. Some of these are tricky things to study because often community health workers work with folks who are most likely to have negative experiences with the healthcare system, right? These are individuals from marginalized and minoritized backgrounds who might not previously have members of the healthcare workforce who they can trust. And so I think they might continue to have negative communication experiences, even if they have a great community health worker who's working with them. And this is a long slope that community health workers are slowly helping to move the needle on. In terms of health outcomes, there's a whole host of specific conditions for which we've seen improved health outcomes among populations working with community health workers. Specifically, we know that community health worker programs can improve management of diabetes, hypertension, HIV, and asthma in children. We also know that community health worker programs that are focused on pregnancy and the perinatal period can result in decreased rates of low birth weight and increased access to prenatal and postnatal care. And then in terms of healthcare costs, which are a really important part of the equation, especially for health systems and payers who are considering how to sustainably finance these programs, we've run 3 randomized clinical trials of our community health worker program here at Penn. And across these 3 trials, we saw a 34% reduction in hospital days, so in inpatient utilization among patients who received the intervention. And this really shows you what that looked like over time. So across 2 studies that followed patients for 270 days, so 9 months post-enrollment, we found that while in the first month you can already see a little bit of a difference, you really saw a divergence around 2 months in healthcare utilization. And this persisted throughout the 6-month intervention period for this study. But interestingly, even in the 3 months after the study ended, we still saw decreased utilization in the intervention group as compared to the control group. So in an RCT, the highest quality of evidence, we saw not only an effect in terms of decreased utilization, but we also saw that effect persist even after the intervention ended, which I think speaks to the longstanding impact of some of the things that community health workers can do for patients and families. One of these studies also did a return on investment calculation, so looked at the cost of the program and then looked at the return on investment in terms of decreased acute care utilization, and found that for every $1 invested by a Medicaid payer, this community health worker program would bring back $2.47. So incredibly cost effective, not only addressing social needs, but really generating this positive return on investment. And then in a recent study, so the 3 RCTs that I presented to you all took place at Penn, but more recently our team has worked on implementing our community health worker model across the country, including at Ballad Health in Tennessee, as you saw. In this study, we implemented Impact at 5 sites across the country and did a similar evaluation, and we saw significant reductions in utilization at 3 of these 5 sites. I'll say 1 site wasn't able to complete the evaluation, and the 4th site saw no change. But this study was also implemented really at the peak of the COVID-19 pandemic, when there were a lot of other factors influencing patterns of healthcare use. So we were impressed that we were able to really replicate our reduction in utilization at many, though not all, of these sites. At 1 site in particular, which is an integrated delivery system, meaning they serve as both payer and provider for a specific population of patients and are therefore really able to track utilization across all care settings, they found that patients who received the intervention had fewer days spent in the hospital at 6 months, had more primary care visits at 3 and 6 months, and had increased rates of social needs screening completion at 3 and 6 months. So again, really showing not just a reduction in acute care utilization, but also increased primary care engagement and potentially having social needs identified and addressed more systematically, which could drive improvements in long-term health. I'll caveat that these results aren't the same in every study. Among children with asthma in particular, this is of interest to me as a pediatrician, community health worker interventions have been shown to reduce hospitalizations in some studies, but not in others. In addition, other randomized controlled trials, a famous one was done out of the Camden Coalition just across the river here in New Jersey, found that there was no significant reduction in healthcare utilization for an intervention that really focused on community health worker support and navigation for the most medically and socially complex patients. So I'm not going to tell you that lowering healthcare costs is a slam dunk for every community health worker program. I think it's hard to do, but I also think it's something that's possible. And so it's important to show that these programs can demonstrate value, not just in terms of the tremendous value that CHWs bring to the community in addressing needs, but also in terms of measurable healthcare costs. And then CHWs play a really critical role in advancing health equity. I think as you saw from our 2 community health worker stories, CHWs are often members of minoritized communities themselves. And I think that really advances their ability to connect with families, but also to advocate for improvements to their communities. This is a really excellent qualitative study that focused on the experiences of community health workers, and I encourage you to read the whole thing, but I'll highlight a couple of quotes that I really liked from community health workers in this study. One of them, so this was a photo voice study where they submitted pictures and then spoke about them. One of them highlighted closure of a supermarket in their neighborhood and said, this was our local market. It had good prices, an ATM, and a money sending check cashing inside. During COVID, it shut down. We're not getting a new market. And you can imagine that someone who lives in this community and knows about the challenges people face in accessing healthy food and accessing fresh food will counsel families differently than a clinician who comes from a different neighborhood and might say, these are the foods that I recommend you buy, but not be able to tell them, this is the closest supermarket you can go to, this is where you should go, or even empathize with them and say, listen, I know it's been harder to access food since the pandemic. Here are some suggestions for what my family has been doing themselves or the other patients I've been working with are doing. So their ability to be a part of these communities, I think, plays a big role in their ability to promote health equity. And then this is another quote from this study where a community health worker said, I've been discriminated against on several occasions because of my way of speaking, my physical appearance, by the native people of this country. The CHW is a first-generation immigrant. Sometimes they see us as immigrants, as nuisances, as people who come to steal their jobs. Even at work, doctors and interpreters can discriminate against you. As much as you want to help, they can see you as a hindrance. I present this quote because it's hard to hear, right? It's horrible that the CHW experienced this, but at the same time, I think their shared experience with patients and families who experience discrimination in the healthcare system really allows them to support families through that experience and really also to feed that back to the healthcare system and say, hey, these are ways that you can improve and make care better and more equitable. And so I'll highlight here that I think CHWs can promote health equity at the individual level by advocating for and with their clients to make sure they have access to resources in healthcare. At the institutional level by improving cultural and structural competence and quality of care, and educating clinicians and leaders, which can result in changes in hospital policy. And then really at the societal level, right? Advocating for social justice within their communities. For example, helping employees advocate for better working conditions, and CHWs have been a really important partner in advocating for sustainable CHW program funding. One really cool CHW program that we worked on here at Penn that I'm happy to talk more about if there are questions, I'm really focused on having community health workers mentor hospital executives. And the goal here was really framed around this quote from Brian Stevenson, which is, we cannot create justice without getting close to the places where injustices prevail. We really have to get proximate. And so what happened in this intervention is we had community health workers who mentored healthcare executives and actually brought them into West Philadelphia, showed them their communities and the challenges they faced, and talked to them about what they thought the community's perception of the health system was and how that could be improved. And then they sat in for a few days on all of the executive meetings and really provided their voice and community perspective. And our hope really was by flipping this mentorship paradigm, right? Thinking about the CHWs as the mentors and the executives as the mentees, we could really get the healthcare executives closer to understanding how the community perceives the hospital and health system and what the things are that are most important for us to change. So I'll talk now a little bit about future directions for CHW programs in general, and then also the next steps in my own work. For CHW programs overall, I think a big focus for the future is sustainable financing. We know that when these programs are funded by grants that expire after 1 or 2 years, this can result in loss of skilled community health workers who no longer have their jobs, and in interrupted services for marginalized communities, which can then contribute to distrust, right? If you have this great CHW who you build a relationship with and you find out they can't support you anymore, and that can really have a detrimental effect on your relationship with the healthcare system. This is changing. Fortunately, as of April 2022, half of all states had some mechanism for financing CHW support through Medicaid. However, a lot of the time this funding is restricted to specific community health worker functions or specific populations. So just for patients with diabetes or just for patients with asthma, which can make it tough for CHWs to support everyone who needs it. And for people who might not fit neatly into one category of needing support, like both of the patients who you heard about from Cheryl and Brianna. There's, I think, still a need for continued high quality, rigorous evaluations. A lot of the studies of CHW programs are observational studies without a comparison group, which can sometimes be misleading, making it hard to really measure effectiveness. I think it's also important for future evaluations to really look at which components of community health worker programs are most essential to success, and a targeting of these interventions. So who is most likely to benefit, and knowing that CHWs are a really critical but also really limited resource, how do we make sure that they are supporting the patients who need it most and who stand to benefit most? And then I think it's really important that community health workers themselves are involved in evaluation at all stages, from designing the evaluation study through disseminating their findings. I also think it's really important to think about translating evidence into best practice. So we know a lot now about the best practices for community health worker programs, including selecting community health workers based on membership in the community served, providing really supportive supervision and support for CHWs themselves, making sure that CHWs are adequately compensated, and giving them pathways for career progression. There's been a push towards CHW certification, which has some benefits like standardizing training, legitimizing CHWs, facilitating reimbursement. But there's also a question of whether certification, if it requires certain things like a bachelor's degree, might exclude some people who would be really wonderful CHWs based on their empathy and ability to connect with patients. And so I think it's really important that we consider, as we implement certification, how to make sure that all CHWs who have the right set of skills can get certified and then can get the benefits like an increased level of income that come with certification. And then there's also a need for program level standards. So it's great to certify individual CHWs, but you really have to make sure that they're supported and given the guidance that they need to do their best. In terms of my own work, I'm really interested specifically in the population of medically and socially complex children. At CHOP, we've been screening families for social needs for the past few years. And one of the things that we've found are that children with complex chronic conditions, or CCCs, have a disproportionately high burden of really every social need, particularly mental health needs. But you can see on this chart also food, utility, transportation, and housing needs. And when we talked to these families, they really told us that they want longitudinal support in addressing their social needs, right? One of these caregivers really described the work that CHWs do, saying it would be good to have someone pick up where somebody else leaves off, where you don't have to keep rehashing your own situation, so that once you leave the hospital, you know people are still willing to help you. And it's not like, oh, we just threw you into the deep end and said swim on your own. Most existing CHW programs in pediatrics are really condition focused, so focused on diabetes or focused on asthma. And something that came out of our social needs screening data is really the need for a community health worker program that's not condition specific and that focuses on providing this social support and connection for all medically and socially complex kids. And so that's what I'm in the process of building with my current work, which is funded by a K award from the Agency for Healthcare Research and Quality. What we've been doing is looking at our social needs and healthcare use data to figure out which populations to target, doing user-centered intervention design interviews with community health workers, with healthcare providers, and with families themselves. And we're hoping that'll feed into a pilot RCT of an adaptation of adult impact interventions specifically focused on medically and socially complex kids. I'll also highlight here that promoting health equity really requires building better and more equitable social service systems. So we know that our community health worker programs and our social needs screening programs in general are only as effective as the programs and services that we're able to connect people to. And so while I've talked mostly about my work focused on community health workers today, I also have a portfolio of work that really tries to move upstream and think about the programs that serve kids and families living in poverty, like WIC, SNAP, and Medicaid, and how we can make sure that they're designed to serve families. One thing that we've looked at in particular is WIC modernization. As you guys know, the WIC program is a really important source of nutrition support and education for low-income kids and families, but it's also a pain to access, right? You have to call your local WIC office, go in person, get your card reloaded in person, and then you have to find eligible products in store, which one parent described to me as like a scavenger hunt every time she goes grocery shopping. So we've been working with folks at Pennsylvania WIC to try to make it easier for families to get nutrition education remotely, to get WIC appointments scheduled virtually and on their own time, and then making sure that WIC products are easy to identify in stores through things like a WIC shopper app, and then also clearer labeling. On the Medicaid side, we know that the burden of recertifying for Medicaid every year can be a lot for some kids and families, especially for medically complex kids and kids facing a lot of social needs. So one thing that we've worked with the state of Pennsylvania on is implementing continuous coverage for kids from birth to age 6, so that once you enroll in Medicaid, you won't be disenrolled until after your 6th birthday, and you can continue to access care during that really critical period for your health and development. And with that, I'd be happy to take your questions and comments. Again, thank you so much for the opportunity to present. It's really been an honor to be here and to be able to amplify some of our community health worker voices along with my own.
Thanks very much for your talk. There are folks on the line that are practicing clinicians, but also community health workers. So I would like to give it a moment and hear what folks have to say. Any people here have a question?
Yeah, I have a question and a comment. First, thank you very much. A great presentation. I'm hoping I can steal many of your slides for ones that we do here. But I really have been talking to lots of people about the workforce issues with CHWs and the fact that we're not training them fast enough. And then there are also, a lot of them are leaving sometimes for higher paid jobs or just because of sort of the burnout. I just wonder if you could just talk a little bit more about what you're seeing from the workforce issues and what we can do more about that besides just paying more.
Yeah, I think that's a great point, and certainly something we're seeing as well. It is both a challenge to hire and train community health workers at the pace that we need them, right? Because we know there's such a huge demand for these services, especially as social needs screening rolls out. And it's a challenge to retain good people in these roles. I think two things that we've been thinking about are first, thinking about creative approaches to hiring. And again, as I talked about, one of the most important qualities for community health workers is that empathy and natural ability to connect with people. And so rather than just hiring through your typical job posting on a job board, a lot of our partner organizations and our own hiring program here at Penn does proceed a lot through our relationship with community-based organizations. So we often, through the CBOs that we know in West Philly and through our existing network of community health workers, are able to say, who do you know, who is in your community who is doing this kind of work, or who you think would be really great for this role? Who do you know who has had experiences with the healthcare system and is motivated to help others and to get them improved? Several of our community health workers on the pediatrics side were have kids who were patients at CHOP and really have channeled their experiences, good and bad, in supporting other families through that process. So I think thinking about creative ways of hiring and recruitment that really get at the skills and community connection. And then to your second point about retention, I think support, supervision, and then having we think about them as like career ladders and pathways, right? I think in terms of support and supervision, we know that burnout is a huge risk for CHWs in the same way that it's a risk for us as clinicians, but often even more because they're really dealing with the most acute and complex social needs and dealing with them in a population that's very similar to their own, where there's often a lot of identification and empathy that makes it tougher. So making sure that they have support from social workers in addressing their needs, but also have support in processing the experiences that they have. So our community health workers all have social work supervision, both for the work that they do, but also social work supervision focused on providing them with mental health support and resources to manage the stress of their job. And then really providing career ladders. And that's not just to say advancing from a community health worker to a CNA to a nurse, because we know that might not be the right role. Some of our community health workers have advanced from being patient-facing community health workers to being CHW trainers, to doing CHW advocacy, right? So having multiple pathways for career advancement within a health system that aren't just advancing up the or advancing to different healthcare roles, but really advancing to different CHW roles that might allow them more capacity for supervision, for education, for advocacy. I think building that in along with appropriate supervision and support can help improve satisfaction and retention.
Thank you. I wonder if you might talk about the strengths and weaknesses of the different structural models for community health workers, in that you illustrated a great example of the strengths of CHWs working for health systems in being able to embed as mentors. But what are some of the weaknesses in that model versus, say, a co-op approach where CHWs have more leadership within the organization and access to kind of more rights and benefits? Could you speak to that, please?
Yes, I completely agree with you. I think there are strengths and limitations of the health system-based CHW model, and I appreciate you bringing that up. I do think one of the limitations, right, is if you're a CHW employed by a health system, you're still subject to all of the health system-based regulations and rules around employment, around advancement, career ladders, things like that. I also think it can make it hard sometimes to set the right bounds for your work, particularly for patients who seek care across multiple health systems or who might only engage with the health system in particular time periods of stress, but might benefit from CHW support in other times. It also does somewhat tie you to the idea of lowering healthcare costs, which again, I think is a great concept. It's great that we've been able to show it in some of our work at Penn, but it's a trickier concept in other settings. For example, our pediatric CHW programs, some of them are financed by the health system with the thought that they might reduce healthcare costs. And honestly, I worry about that because I think the return on investment for pediatric CHW programs is decades down the line and not necessarily in the 5-year time scale that our health system might want us to demonstrate value. So I think challenges for having CHWs based in healthcare include this requirement to show return on investment, which can be tricky, the challenge with people who are navigating multiple health systems or who might need support outside of the times that they're interacting with healthcare, and then some of the challenges associated with being an employee of a health system, right? In that way, I think the co-op model of having community health workers employed by a CBO really allows them to have their own governance, supervision, and support structure in that context to work with people across multiple health systems and to serve patients at the time that their needs come up. Some of the things like interfacing with healthcare systems can be a little bit trickier when you're outside of that, right? Our CHWs send messages through our EHR and they add themselves through patient care teams. And so some of that is trickier with the CBO model, but I do think there's a lot of benefits of those as well.
Wonderful. Thank you. Any other questions? We talked about wrapping up about 5 till. But thank you so much, and thanks for your willingness to meet with us and our community health worker team at some point in the future. Really love the work that you do. Thanks so much.
Thank you so much for having me and looking forward to continuing the conversation.
Thank you. Thank you so much, Dr. Vasan. You were wonderful.